Hi, everyone. Thank you for joining us in this event today. We hope that you have connected successfully and that you can hear us well. My name is Eloisa, and along with Camila and Carla, I'm representing the ESPOR KI student chapter. And today we continue our PhD series with a presentation by Diego Yacaman. So Diego graduated from the Public Health Epidemiology master's program at KI, and he's now doing his PhD in epidemiology of diabetes in collaboration with the Center of Epidemiology and Social Medicine at Region Stockholm. So in his presentation, Diego will talk about his project, share some of his work experience and some insights about the process of doing a PhD at KI. So the talk will last approximately 20 minutes. If you have any questions, you can write them in the chat and then we'll address them in the end. So Diego, thank you so much for accepting our invitation. And yep, whenever you're ready.
Thank you very much, Elo. And thank you everybody on ESPOR for the invitation to talk today. Welcome everybody. Yeah, so I will try to make this talk interactive. So if anybody has questions, please, as Elo mentioned, just write them in the chat. And I don't know what the organizers think, but I'm also okay with being interrupted or at any time. So without further ado, I'm going to start with the talk. I will talk a little about I want to start with the basics of epidemiology of type 2 diabetes, a little probably more specific in Sweden. What do we know about risk factors? A very simple introduction about the consequences of type 2 diabetes. Why is this a public health problem of relevance? What is the current areas of research in prevention and early detection of type 2 diabetes specifically? And then a little more into what my PhD work is all about, a lot of precision medicine and public health. And I'll give you a couple of examples from my own work. One is a life course approach of the effect of weight and diabetes. And another one has to do with the clinical clusters of risk for type 2 diabetes. So I'll start with probably something very basic that everybody here knows, but well, diabetes is a very wide umbrella term that is used for an heterogeneous group of diseases, of which the most common, 90% of the cases of diabetes are type 2 diabetes. Probably we've heard more about just type 1 diabetes as diabetes of the young, and type 2 diabetes as related to obesity and physical inactivity and this. The reality is, I think, a lot more complicated than this. This is a useful simplification just looking at it, but it really catches one's attention that over 90% are just labeled as the same disease as type 2 diabetes. Although there is a very complex interplay between genetic, lifestyle, social, and behavioral factors that lead to this chronic condition. Around the world, the prevalence of type 2 diabetes is increasing. In high income settings, a recent report showed that the incidence seems to be remaining stable or stabilizing a little bit. However, the overall burden of the disease due to the increased survival and advances in therapy that make people live longer with this condition. So it makes that the prevalence keeps increasing, and this affects the overall burden of the disease. So overall, around 1 in 11 adults has diabetes around the world. Half of the 4 million people who die from diabetes are under the age of 60. So this is also not only a problem of elderly people or advanced age. It affects a wide range of people of all ages. Something about health economy. So around 12% of the global health expenditure is spent on treating diabetes and diabetic complications. And just to say a little bit about how does it look in Sweden. So in Sweden we have a pattern in which it's below low. The burden of the disease of type 2 diabetes is sort of below to those of, for example, the US or China or lower income countries. However, the problem is growing, is increasing, and it is expected to continue increasing. Just in region Stockholm, the prevalence between 2013 and 2018 has increased from around 4% to around 6% overall. It is causing around 4% of the total disability adjusted life years, and with a 48% increase since the 90s. And it has been also shown in some research that expenditure in healthcare for people with diabetes is more than double that of a person the same age without type 2 diabetes. And another important fact is that around 30% of the cases remain undiagnosed. So people can have diabetes for many, many years, can already have even some of the complications or changes in their pathophysiology or how their body is working, and not show the symptoms, don't feel bad at all. So this keeps hidden from them, from the healthcare system, until something more severe happens. And yeah, just a little about the important risk factors that we know for diabetes. So, I mean, the risk increases with age. Ethnicity seems to play a role. The family history of type 2 diabetes is really important. So, contrary to what people, or even what I used to believe, is type 1 diabetes has a lower genetic risk than type 2 diabetes. The difference is the genes that cause type 1 diabetes are better identified, whereas there is a wide variety of genes that affect the risk of type 2 diabetes. So with the latest genome-wide association studies, with the whole genome of a large number of individuals, it cannot be explained more than 40% of the heritability of this condition. So although it's quite genetic, it is not really understand how genes affect the risk of type 2 diabetes, but they do have a very important effect. On the other side of things, there's also quite important impact of socioeconomical and behavioral risk factors. So, I mean, basically, just to give a summary, as the WHO just summarizes with unhealthy diet. Around the world, also 1 in 3 people are overweight, and around 1 in 10 are obese. Now the pandemics are quite popular, so we have been talking about an obesity and overweight pandemic since over 10 years now, because they have an important effect in all cardiovascular and metabolic chronic conditions, and diabetes is no exception. Important risk factors for type 2 diabetes have only been increasing in Stockholm. So you can see the rank of the most important risk factors in the global burden of disease. Although, for example, high body mass index or high fasting plasma glucose were already among the top 10 in 1990, they have completely increased and gone up several. Now we're in the second and third most important, followed by the dietary risk factors that are also related to this. Blood pressure, alcohol use. So basically, of the top 10 risks, they are all related to type 2 diabetes in one way or another. And of course, the consequences is cardiovascular complications remain the main cause of morbidity and mortality among people with type 2 diabetes. And among this is one of the major causes of blindness, kidney failure, heart attacks, stroke, and lower limb amputations. So one important thing in when studying diabetes, and one of the difficulties with studying diabetes from an epidemiological perspective, is that a lot of people use it as an exposure for something else. So a lot of research in diabetes is like, okay, so people with diabetes have a high risk of heart attacks or stroke or something like that. And I believe that there's less using diabetes as an outcome per se. So what kind of risk factors lead you to have diabetes? And the more complex part of all of this is, what is the role of type 2 diabetes as a mediator, or the interaction between different effects and type 2 diabetes? So this is a very complicated pathway in which we usually just know parts of it. Just a few words about prevention and early detection of type 2 diabetes. So it has been established since a long time ago how diet and lifestyle modifications are effective in preventive type 2 diabetes. There's a very important and reference studies called the Diabetes Prevention Program. And they found that among people with higher risk of diabetes, they have a glucose level that is not normal, but not diabetic, something in the middle, sometimes called pre-diabetes. They randomize, it's an RCT, so randomize people to receive either placebo, metformin, which is a drug that reduces blood glucose, or lifestyle interventions. And they saw that you could, or in theory, with these people at high risk, you can actually reduce the risk of diabetes or the incidence of diabetes for around 50%. So half of the cases of type 2 diabetes could be preventable with the right intervention for the right person. This has not been able to be generalizable despite international attempts, because of something that probably everybody here in health economics knows way better than me. This is not easy to get these kind of expensive interventions to be cost efficient, or because they're both time and resource expensive. So it has been a lot in focusing in secondary prevention. What is this? So early diagnosis, reduce the number of undiagnosed people, and have a multidisciplinary treatment in order to engage in all the areas that diabetes could lead to complications, from the kidneys to the eyes to the lower limbs, everything. Focus on lifestyle modification, although behavior has been in medicine, I think the history of medicine, one of the most difficult things to actually change. And focus in preventing the complications of diabetes. So what I was talking a little bit before, that there's a lot of research in how to, once you have diabetes, how the risk factors for the outcomes of having diabetes, instead of preventing diabetes, completely from the beginning. Some medications have been studied for this, but if I have to put an example, like to compare, statins, which are drugs to reduce blood cholesterol, have been widely used, and everybody's prescribed statins, even though they don't really have a cholesterol issue. There are some medicines like metformin for type 2 diabetes that is cheap, it is very safe, and could be used in the same way, because it also reduces certain risk of type 2 diabetes and its complications, but this has not happened, also because of more economical reasons. For a more patient-directed approach, there has been, in the last decades, I think, a vast development of multiple risk scores. So very specific risk scores for type 2 diabetes exist, which, I think the baseline, the fundamental of this was the metabolic syndrome, which is just if you have 3 or 4 of the most common risk factors for type 2 diabetes, then you're considered to have this diagnosis, which is called metabolic syndrome, and increases the risk not only of diabetes, but of several other conditions. And from that, more specific tools and more population-specific tools have been developed, such as the FINT risk, which is a Finnish diabetes risk score, QD score in the US, the Cambridge risk score from the UK. However, the generalizability of these risk scores has been quite limited, because they probably do not work as well in other populations, or and at some point, I honestly think it's because everybody wanted their own risk score, and there's so many out there that it's been hard to actually implement in the clinic. One thing they all have in common is they all have a one-size-fits-all approach for this issue. So they assume that the same risk factor will have the same effect in all individuals of all different populations. So we do things like, okay, so high BMI, high body mass indexes increases your risk of diabetes. Yes, but not everybody with a high BMI has a high risk of diabetes. And I don't think it's been, there's a current gap between the individualized approach and the patient-centered approach that we want in clinical practice. For example, the new Karolinska Hospital is based with a patient-centered approach, and everything is focused in that way. But on the other side, when we talk about the epidemiological research, we have a quite reductionist approach, in which we say things like, for example, sex is associated with a certain disease, or men have more cardiovascular diseases than women, but not all men have higher risk than all women. So I think there's that gap about what is a patient-centered approach for clinics and for public health. So the term precision medicine is usually used for genetic studies. I think there's it has been way more developed for the use of genomes and genetic knowledge on the treatment of several conditions. However, for the most, they have been useful for example, the monogenic types of type 2 diabetes, which represent less than 1% of the people with diabetes. Precision medicine is wider than this, even though this is the most common use, is the use of technology to develop and provide individualized prevention and treatment. And even though it includes prevention, there's also a definition of, or there's been more recent talk about precision public health as a separate and related topic. And the use has been described in several ways. One that I like is the use of technology to more precisely describe and analyze public health risk and customize interventions for more specific and homogeneous subpopulations. So the overall aim in my research has been to try to reduce this gap and this reductional approach in epidemiology to identify possibly useful subpopulations of individuals with a high risk of type 2 diabetes. And a common assumption I am doing during the whole study is that there are identifiable and unobserved subgroups of people at risk. Basically, that not everybody who has a high BMI is the same. There are groups of people with high BMI and so on and so on. So now we start a little with what have I been working in my PhD. So I'm finishing my second year of my PhD studies, so halfway there basically. The first study I've been working on is a life course approach for the effect of weight on diabetes, in which we aim to characterize the life course trajectories of weight, different weight categories through life, and to estimate their impact on incidence of type 2 diabetes in adulthood. So we had information from if a participant was lean, normal weight, or overweight or obese. So we have those three categories: lean, normal, or overweight / obese. So I mean, it's not quite as specific. Probably we don't have BMI for everybody else, but we do have data from when they were 7 years old until they were 55 years old. And everybody at 55 was still healthy. So we have that group of people that will develop diabetes after 55. And then we use a method that's called latent class analysis, one of the methods to derive the latent class analysis, and to see if we could identify the different patterns of changes of weight through life. And then after we categorize this, found and categorize these subgroups, we estimated the risk of type 2 diabetes and how much of the risk of diabetes is attributable to each of these independent risks. So what do we find? We found that among men and women, there were 5 different patterns. They were actually, to my surprise, quite similar between men and women. although the percentage of individuals in each of the patterns was a little bit different. Overall, we have that, there's some people that remain in a normal weight category during the whole life. And of course, we use these ones as a reference group. But there's people who start low and then start in lean and then increase constantly over their life. There's people who begin increasing during their early adulthood until they become obese in their middle or late adulthood. And there's people who become obese during quite late in their adulthood. And of course, there's those who remain overweight or obese. One question I always get here is like, why isn't there a group that is reducing? Well, it's because if you keep partitioning groups, you will, with this kind of methods, you will get as many groups as you want. One of my criteria was that it has to be at least 1% of the population in each group. So it's actually something that can be used for public health or useful in epidemiology. And if you keep partitioning the groups, you will get a group of people who reduce their weight. However, they represent way less than 1% of the population because BMI tends to increase. Weight tends to increase through life. So this is just a generalization of the population. And with this very boring table, I just wanted to show you how, compared to the stable normal weight group, all the other groups among men and women had a statistically significant increased risk of type 2 diabetes. If we had measured them all during the baseline of this study, we will just have that conclusion of, so high BMI at this point increases the risk of type 2 diabetes. But we actually managed to say, okay, but we have 5 different patterns of why do you have that specific high BMI at that specific time point? Where is it coming from? And we found that different patterns. And so first of all, if we check just the relative risk, we see that, and this is not impressive at all, that those who had overweight during their whole life and those who became overweight in early adulthood are those at higher risk. But importantly, it seems that those who became overweight in early adulthood have even a higher risk. To prove how much of the risk is related to which of the patterns, then we we calculated the population attributable fraction. So how many of the cases of diabetes in this group were attributed to each of the groups of exposure that we found? And we actually found that at least in this study, in this cohort of healthy adults in Stockholm, around 23 to 28% in men and women and in men respectively could be attributed to increased weight in early adulthood. And this is something I thought it was surprising, and I think it's important because I think that a lot of interventions are aimed, and a lot of focus is currently aimed to childhood obesity. But people in their early adulthood, they are left basically without any help or without any population level intervention aimed specifically for them. And this is, I guess, controversial. I mean, one of my supervisors works in the obesity center of Region Stockholm, and she says, if I have an obese kid, everybody's interested. If I have an obese 22-year-old, no one really, there's nothing special or specific for them. They just get the population level interventions, which were designed with an older population. So I think this is areas of opportunity for development of more precise population level interventions. And I move up now to the second study, just really quickly. In this study, we took a different approach. We tried to see if at baseline we could find different patterns of many risk factors that are related to the risk of type 2 diabetes. So how are people, healthy individuals, could be grouped in different categories. To do this, we used over 7,000 individuals, healthy participants from the same study as the previous one. It's called the Stockholm Diabetes Prevention Program. And in this case, we also used data from a large cohort in Mexico, which was also done with healthy individuals, and given the similar characteristics, we could do the same. The main idea of this study is to categorize different hidden or unobserved groups of individuals into their proper phenotypes or clinical groups using cluster analysis. We used age, sex, education, family history of type 2 diabetes, level of glucose, insulin, and their blood pressure at baseline to see if we could identify any patterns. The results of the cluster analysis I'm showing here. So we found in both running independently the cluster analysis for here in the left, the Stockholm cohort and the Mexico cohort. We found the best solution was 7 groups. We found that the 7 groups do not have a big overlap. And as you can see in this next slide, we found also that here how the patterns of these groups are almost the same. While we did them completely independently for the 2 cohorts, we just ran the same algorithm. The computer decided, and it shows exactly sort of the same phenotype, the same patterns of the different risk factors. So we have age, glucose, insulin, beta cell function. These are calculated from glucose and insulin. The level of insulin resistance, BMI, and systolic and diastolic blood pressure. There's how many men and women, level of education, family history of diabetes. So we came up with these 7 characteristic clinical groups and named them just based on their most most prominent characteristic. It's hard to say what is the most important. However, we have 7 different types of healthy adults. And the risk of type 2 diabetes is significantly different between all of these 7 types of healthy adults. And they follow a similar pattern. If you can see here, maybe the second column for the Stockholm cohort and the Mexican cohort. We have a lot of people with a very low risk. Then we have people that even though they're old, they have a lower risk of type 2 diabetes than the general population. And then we have one that is, they have a low risk and they have a low BMI, low beta cell function, so metabolic predominant characteristics are low. And they have a similar risk than the general population, so we use them as a reference group. And also compared to them, there's also a group which is mostly because of their blood pressure, have a higher risk of type 2 diabetes. Those because of insulin resistance have a high risk. And those because of beta cell failure have a high risk of type 2 diabetes. So we notice that different areas of the pathophysiology of type 2 diabetes are expressed in people at risk in a different way. Yeah, so this is just to show you the survival analysis of this. So we found these are all the 7 risk groups and how we have sort of a very low risk group, a moderate risk group, and 2 high risk groups, and how the pattern is replicated. Although we have a really short follow-up time in the Mexican cohort, the downfall of this study, but we can see the same pattern even already in 3 to 4 years of follow-up. So the conclusion is we found the 7 characteristic clinical clusters of healthy adults, and they are associated with the risk of type 2 diabetes. They were replicated in a completely independent cohort with the same results. And I think the most important thing here is can these results be used for creating better intervention strategies and more individual-centered intervention strategies, knowing which cluster do you belong to can make the difference between you getting a diet and physical activity or actually getting some medication, or probably not worrying about this at all and using the resources in a more efficient way for someone else. That has to be proven, I think, in the future. But that is, I think, the aim of my studies. And with that, yeah, thank you for listening. I hope you found it interesting as I do. And yeah, I'm open for any questions if we still have some time for that.
Thank you, Diego. Yes, we have some minutes, and we got a question. So regarding your first study, did you assess any predictors of the trajectories, for example, dietary patterns? And would you assume that there is a causal relationship between the patterns you identified in type 2 diabetes?
Yeah, they're really good questions both. And the first one is, we are interested in knowing the determinants of each trajectory, but we thought that could and should be probably the next study, the next step of these studies. Now we focus in describing that these trajectories exist. The next step would be like, why do they exist and what consequences do they have? For example, we know they have a high risk of type 2 diabetes, but is it the same for the complications of type 2 diabetes? And what is the role of socioeconomic position, for example? I'm especially interested in these different trajectories. One difficulty I found there is that, I mean, the cause-effect relationship between these trajectories and type 2 diabetes, I think we can say that it's most probably there, because everything happened before they had type 2 diabetes. So we have temporality, we have biological plausibility, we have a sort of a mechanism, and we think it's causal. But if we want to study the determinants, we have their information since they were 7 years old. So everything we sort of look into it, the causality becomes a lot more complicated. Some of my colleagues are interested, for example, in maternal obesity, paternal obesity, or this, then I think that would be easier. But yeah, it becomes really complicated to create the DAGs or the causality diagrams for the determinants of the trajectories.
Yeah, thank you. And well, we know that it might be a bit early because you're still working on your project, but since you have been working with Region Stockholm, do you think that these results will have an impact in clinical practice, or that they can influence policy, maybe develop some kind of tool or have an impact? What do you expect?
Yeah, well, I hope so, and I certainly think that they hope so. I think that is the ultimate goal of doing this kind of research. However, we will have to see what evidence says about this. There is a lot of controversy in using medications for pre-diabetes, for example. And some researchers say, why would you medicate someone for a pre-disease? So the prophylactic use of medications can have really good consequences and can have very bad consequences. I think, and the goal with this is, we are lacking the precision. So it has been proven that, yeah, you shouldn't give medications to the whole society. It's not good for many reasons. But it's also been proved like, hey, this person already has a lot of complications. That's very, very common. It should have been receiving medications from before. So hopefully we can design some sort of tool that would help to better identify those at risk and to give them not the same one-size-fits-all intervention, but with some data or with some knowledge, say, I think you could probably benefit more from this kind of intervention. And you, other person, you benefit more from this other kind of intervention. So that would be the goal.
And also, so considering that it is possible to create this kind of patient segmentation, and then if you introduce specific interventions for each one of them, so in Sweden, and perhaps more specifically in Stockholm, because that's what you're looking at, you can also follow these groups later to see the outcome of those interventions, right?
Exactly. So, I mean, that I think is, when I think about it, it will take a long time to know what intervention is better for what group. But I think it's a good step forward to know that the groups exist. And that possibility is there to do more precise health economics public health, everything before a diagnosis is made.
Yeah. Okay, we got another question. So in Africa and Southeast Asia, less than 50% of all diabetics of type 2 are overweight. And do you think that we also miss clusters of people if the intervention primarily looks at BMI?
I mean, yeah, I think that's one of the current issues, I think, of modern or medicine or evidence-based medicine, is that evidence is usually comes from a high-income country and a certain targeted population, and then we just decide to sort of do the same with all people. So what we found that was interesting is that even though we found the same patterns of individuals, some of them are more common in Mexico, in this case, and some of them are more common in Sweden. So let's say you have an intervention that happens to work for the most common group in Sweden, you will see with a strong effect in Sweden. But if you apply the same intervention in Mexico, it will probably not be as good. So I think we have to replicate these kind of methods in as many settings as we can. And the main idea is to make this, setting specific, and to get something that can work everywhere is never going to happen. So I think instead of that, we have to develop the methods to identify what someone in some place needs and provide them to them more specifically. So yeah, in the clusters, we have a group that is, even though they are not overweight, they have a higher risk of type 2 diabetes. So I would say maybe, in Africa and in other areas of the world, this group is larger. And instead of diet and exercise, then you need other kind of interventions for those populations.
Yeah. All right. Thank you so much, Diego. It was extremely interesting to hear about your project, and it is definitely relevant, and we hope to see it being used in clinical practice in the future. So thank you very much. So I just want to close this event, just showing you the next events that we'll have. So next week we have a presentation about nutrition economics. And then we follow with some other talks about professionals in health economics and outcomes research, and we'll have other talks on the PhD series. And also, we are recruiting people for our board. So if you have an interest, if you would like to join us and help us in organizing events, please send us your CV and some words of motivation. And yeah, we are growing, and we need more people. So thank you everyone for joining. Thank you again, Diego, for your presentation. And yeah, hope to see you all next time.
Thank you. Bye-bye.
Thank you.
Bye.